Hello there, my name's Declan Costello. I'm an ear, nose and throat consultant and laryngologist at Wexham Park Hospital in Slough. I'm going to talk to you today about spasmodic dysphonia, which is a rare condition characterized by spasm of the vocal cords, the vocal folds, and gives a very characteristic and unusual sounding voice. In the normal run of things, most people in life would probably never encounter somebody with spasmodic dysphonia, but in laryngology practice, we see a reasonable amount of it. So I'm going to spend the next sort of 40 minutes or so telling you all about it. So I'm going to start by sharing my screen, if I may. Let's just bring this up here. There we go. So good. I hope you can see that, talking about spasmodic dysphonia. I'll start just with my usual nod to Saint Blaise, the patron saint of the throat, who reputedly removed a fishbone from the throat of a young child and hence was saved the child's life and was sainted after that. This statue is in the lobby of the Royal National Throat, Nose and Ear Hospital in London, and it'll be transported to the new site of the hospital in the coming months, I understand. So let's talk about spasmodic dysphonia. Spasmodic dysphonia is a focal, task-specific dystonia of the larynx. A dystonia is a disorder, a neurological disorder characterized by abnormal muscle movement. And by focal, I mean it just affects the vocal cords, and we'll come on to that in just a moment. And by task-specific, I mean that you have to be doing a particular thing to invoke the spasm. It doesn't happen at times other than when you are doing this particular task. It's spasm of the intrinsic laryngeal muscles, in other words, the muscles within the framework of the larynx, not affecting the strap muscles or the anchoring muscles around the larynx, or at least not directly affecting them. It is rare, it is very rare, probably between 1 and 4 per 100,000 of the population. So it's an incredibly unusual condition and hence not very often heard and is very often missed in clinics. It affects females significantly more than males in a ratio of about 9 to 1, and the age of onset is usually between the ages of about 30 and 50. And we recognize a number of different types of spasmodic dysphonia. There is adductor, abductor, mixed, and tremor associated with SD. So adductor spasmodic dysphonia, as the title suggests, is when the adductors are going into spasm. So the muscles that bring the vocal cords together are going into spasm. Abductor, abductor spasmodic dysphonia is exactly the opposite. So the muscles that move the vocal folds apart are spasming, and we'll see examples of this as we go along. Mixed spasmodic dysphonia is characterized by a little bit of both. It's pretty unusual to get mixed SD, but that can happen. And we'll talk about tremor as well. Tremor quite often coexists with spasmodic dysphonia and can be a little bit difficult to distinguish from it. So I'm going to play you an audio clip now of a patient with spasmodic dysphonia.
When a traveller came along, wrapped up in an overcoat, they agreed that the one who could make the traveller take his coat off would be considered stronger than the other one.
Now, I hope you could hear that. You may not have been able to hear it so clearly, but essentially this is a patient with adductor spasmodic dysphonia. And in adductor spasmodic dysphonia, there are breaks in the audible sound as the vocal folds snap shut. And for the musicians amongst you, this would be a staccato kind of voice. So the voice, is with the voice cut suddenly, and the vocal cords snapping shut. So the vocal cords are snapping shut rather than allowing for a fluent sound. So on initiation of phonation, the vocal folds are snapping shut. The next example is abductor, abductor spasmodic dysphonia.
Which was stronger than a trunk forming up to the coat. They agreed that one who could make the traveller take his coat off would be considered stronger than the other one.
Now, again, I don't know how clearly that came across, but in this example, in abductor spasmodic dysphonia, the vocal folds are bursting apart and you're getting breathy breaks. So rather than staccato stops, you're getting breathy breaks. So the voice sounds like this with uncontrolled bursts of air when trying to produce a fluent sentence. So that's the very key difference between adductor, staccato, and broken up like that, and abductor, which is more of a breathy break like that with breath escape. How do we make a diagnosis of spasmodic dysphonia? Well, it's on clinical grounds. There are no specific diagnostic tests. There are no blood tests. There are no scans. There are no electrical tests that you can do that are very specific for spasmodic dysphonia. And the issue really is that the diagnosis for these poor patients is usually made after a delay of many months or years. In fact, the average time from the onset of symptoms to the diagnosis being made is about 4 years. Because the voice is so unusual, people are treated with psychotherapy, hypnotherapy, aromatherapy, physiotherapy, and a variety of other things before anybody actually realizes what's going on, because the sound of the voice in a patient with spasmodic dysphonia can give the impression of nervousness or hesitancy, and might lead to the thought that this is a sort of psychogenic thing. It's not, and I'll come on to that. But people end up having psychological therapy to try to overcome what's perceived to be nervousness or a psychological problem, when actually fundamentally it's about a neurological disorder. So there's a delay of several years usually. And endoscopy, when you look at the vocal cords with an endoscope, the vocal cords essentially look structurally normal. You may see some spasms, but interestingly, in my experience, when you do endoscopy, the voice sometimes sounds a bit better, and we're not really sure why that might be. So the diagnosis, I mean, it's difficult to distinguish between functional muscle tension dysphonia, as I say, that the two can mimic each other, psychogenic aphonia, in other words, that situation where the patient has completely lost their voice because of a psychogenic issue, and tremor. So trying to tease out the different aspects of which is very important. Spasmodic dysphonia has a pattern which can be elicited, and there are certain sentences that we'll talk about in a moment where you can really bring out the spasm. There are no conversion symptoms. These are not, there is not a sort of psychological thing that triggers this. And interestingly, there's no evasion of voice recovery. If a patient has muscle tension dysphonia, then there can sometimes be psychological issues that mean that they find it difficult to get back to their normal voice. And therapy can sometimes not be very helpful. But actually, in spasmodic dysphonia, there is a very genuine and highly engaged interaction with speech and language therapy to desperately try to get the voice better, but it just doesn't. And there's a gradual onset, although this varies with vocal task and stress levels, and we'll talk about stress levels in just a moment. How does spasmodic dysphonia start? Well, it can often come out of the blue spontaneously. Some patients report that the spasm will start with a respiratory tract infection or an emotional event, and that's why for a while it was thought that this was a psychogenic problem, but we now understand that it's not. And whatever the cause, the spasmodic dysphonia having started, it's sort of there for life, and it can, people have phases where it's a bit better or a bit worse, but actually fundamentally the condition of the SD is there pretty much permanently. So let's talk about the diagnostic markers for spasmodic dysphonia. It's action induced, in other words, the spasm only happens when you initiate movement of the vocal folds. It is task dependent and task specific, so it only happens when you're doing a task, and it is very specific to the task of speech, which is very odd. And we'll talk about that in a moment, but there are certain things that make it worse, and there are certain situations where you're using the voice and it can just disappear completely. We've said already that in adductor spasmodic dysphonia, there are voice breaks in vowels. In abductor, you get these breathy breaks and prolonged vowel onsets. And in both types, you get phonatory arrests. The voice stops either with a cessation of the vocal folds moving at all, or with a spasm of the vocal folds moving apart. One of the issues that can sometimes arise is that the falsetto and singing and in whispering, the spasm just disappears entirely, which is an interesting observation. I'm going to pause my sharing for a moment, and I'm going to come back to you in just a second. Hello, I'm back with you. I'm going to share my screen again now. So we were just saying that in falsetto, in using the voice in different ways, in whispering and often in singing, the spasm can disappear. And I think this says something about the nature of the and I'm back again. So I'm going to share my screen again. It's just a very interesting phenomenon that it's specifically related to speech, that the voice is a problem, and very often not in other modes of voice usage. There's no pain on palpation when you feel the patient's neck. So, as I say, high pitch and falsetto is quite often a useful diagnostic test for spasmodic dysphonia, because the spasm will sometimes disappear completely. Patients are able to perform vegetative tasks, by which I mean coughing, yawning, often shouting in anger comes out normally as well. And patients can usually sustain a single sound of an E, whereas in muscle tension dysphonia, the characteristic voice will, the tension in the voice will still be heard. In spasmodic dysphonia, quite often that sustained E sounds normal. Modal pitch, in other words, chest voice sounds difficult, but falsetto often works fine. And pitch change and prosody are reduced, and that's really just a function of the patient trying to control their voice and trying to control the spasm, although it's entirely outside of their control. So the typical characteristics that are often described in a patient with adductor spasmodic dysphonia are tight and strangled, in adductor. In abductor, you would be thinking about breathy bursts of sound. So a couple of the sentences that we use for diagnostic purposes would be things like, Brian bored me over dinner, for adductor, and that would come out sounding like, Brian bored me over dinner. That sort of thing, where you get a staccato sudden stop with loss of airflow. And with abductor spasmodic dysphonia, you might use a sentence like, Sister Sue cut up a potato, which could sound like, Sister Sue cut up a potato, with those breathy breaks. And one of the key diagnostic tests, I think, particularly in older patients, is to listen for a sustained E on one note to see if there's any tremor, because that tremor can often be can often mimic adductor spasm. So in the patients we see, they will often say that the spasmodic dysphonia, the spasm is better first thing in the morning. Sometimes patients will wake up and for the first 20 minutes, half an hour of the day, their voice can sound almost normal. It's typically worse with stress. It's not caused by stress, but it is worse with stress. And patients usually will say that situations like using the telephone or making presentations are particularly problematic. We've said already that the cry and laugh and coughing is normal, swallowing is normal, there's no pain, and some patients say that actually their spasm is better when they have some alcohol. The dysphonia severity reduces on a sustained vowel, as I say, and the voice is always worse in conversation than on that vowel prolongation. In the adductor spasmodic dysphonia, we get that tight, strangled quality, hyperadduction of the thyroarytenoid muscles, and some pitch breaks and those phonation breaks, as I say. Average age of onset is about 38, and the Americans describe about 52 cases per million. On laryngoscopy for adductor spasmodic dysphonia, you may see a sort of shudder, you may see some of the spasm, and very often patients will adopt muscular tension in addition to the spasm to try to compensate. So there may be some anteroposterior constriction. Abductor spasmodic dysphonia is significantly less common. It's a spasm of the posterior cricoarytenoid muscles, the PCAs, and there's a whispery sounding voice with breath escape, air escape periodically, and aphonic periodic whispered segments. And you know, it can sometimes be a bit difficult to differentiate abductor spasmodic dysphonia from conversion aphonia. In abductor spasmodic dysphonia, clearly you're going to see a gap on adduction, and you might imagine that the vocal folds, as they come together, look as if they're not wanting to touch each other because they're hot and they're bursting apart. E-he is quite a useful diagnostic test. We've said already that there aren't really any specific investigations available for spasmodic dysphonia, so we will refer patients to the neurologist if we're concerned that there might be other neurological conditions. I've said already that spasmodic dysphonia is a dystonia that is specific to the larynx, and generally if the dystonia starts in the larynx, it's going to stay in the larynx and won't move elsewhere. But if there are other abnormal potential neurological issues, then those need referral to a neurologist. As you can imagine, the voice in spasmodic dysphonia is so unusual that it can cause significant socioeconomic problems, social isolation, patients losing jobs, and it's an immensely stressful condition, and compensatory neck postures can happen as a result as well. So thinking about the treatment for spasmodic dysphonia, it's back in the 1960s that a paper was published suggesting a neurological basis for spasmodic dysphonia. Through the 60s, various behavioral treatments were suggested, none of which was successful. And in 1976, Dido demonstrated voice improvements, but it wasn't a sustained voice improvement if you were to cut the recurrent laryngeal nerve. So if you cut the main nerve that goes to the larynx, then the voice improves, but only transiently. Miller in 1987 and his colleagues were the first to report changes with botulinum toxin, and it was in 1994 that Blitzer produced the first large series of spasmodic dysphonia. And now we understand that spasmodic dysphonia, or at least in current laryngological practice, botulinum toxin is the mainstay of treatment. There are various different preparations of botulinum toxin. The vast majority of us are using botulinum toxin A, and there are widely available. There are three main proprietary names: Dysport, Botox, and Xeomin, and this is what they look like. And botulinum toxin B is much less widely used. We wrote a case report a few years ago about a patient who had botulinum toxin B into his larynx extremely successfully, and he had a coexistent epiphora, so a weeping eye, and the Botox, the myo block, botulinum toxin B, had worked very well for that. Surgery, we're going to talk about. Voice therapy has a role in spasmodic dysphonia for sure, but it needs to be understood that spasmodic dysphonia can't be cured or treated with voice therapy, but it can certainly help to control some of the symptoms. So the treatment of spasmodic dysphonia with botulinum toxin involves injections into the affected muscles. Now, in the case of adductor spasmodic dysphonia, that is into the adductors, and we typically inject the thyroarytenoid. Now, of course, the primary adductor of the vocal folds is actually the interarytenoid muscle, but you can't really get to the interarytenoid particularly easily, so we actually inject the thyroarytenoid muscle through the skin of the front of the neck, which is relatively easy to access. Or in the case of abductor spasmodic dysphonia, you're wanting to inject the posterior cricoarytenoid muscle, the PCA, which is around the back of the larynx. And this can either be done with or without neurophysiology. And by neurophysiology, I mean electromyography and EMG machine. In my practice, I always use EMG, and I'll show you that being done in just a moment. So botulinum toxin type A is the main treatment, either Botox or Dysport, more recently Xeomin. And it's worth remembering that Botox and Dysport and Xeomin all talk about units, but 1 unit of Botox is not the same as 1 unit of Dysport and is not the same as 1 unit of Xeomin. So you just need to, if you're going to jump from Botox to Dysport to Xeomin, you need to make sure that you get your dosing correct and just don't give the same number of units across the 3 preparations. So we've been using botulinum toxin, as I say, since the 1980s. It is the mainstay of treatment in most centres. It has the advantage that it's extremely well established, it's safe, long-term track record, and it's very well tolerated, and it works extremely well. The disadvantage, of course, is that it's temporary. It works for a few months, typically about 3 to 4 months. The patient will have an injection, the voice will be great for a few months, and then the spasm will start to creep back in again, and they'll need another injection. And this is then a recurring pattern in which patients have to have injection after injection after injection. The patient is then committed to having long-term treatment. It does mean also that you're getting peaks and troughs in voice quality. So you'll have troughs where the spasm is bad and peaks where the spasm has gone away. And in all cases, or in the vast majority of cases, when a patient has just had their injection, for a few days afterwards, the voice tends to be a bit breathy, and that varies a bit from patient to patient. So it's not ideal. So for newly diagnosed patients, I typically will start with a low dose. I don't want to overtreat the patients initially. It's interesting to know that males tend to require lower doses than females. So I will usually, when I'm diagnosing a patient who's never had treatment before, I will usually start with a very low dose, and you accept the fact that actually that low dose may not do anything initially, but you can then titrate it upwards in future if necessary. Patients should be warned that they may very well experience a breathy voice for up to a couple of weeks, but usually only just for a few days. And they may experience some symptoms of aspiration, in other words, coughing on liquids, but again, this is usually just for a few days. If you would like to see an information sheet about that we hand out to our patients, then you can just search on Google for UHB Spasmodic Dysphonia, and that will take you straight to this patient leaflet, which is extremely helpful. So what's the role of surgery? Well, I've said already that Dido was cutting recurrent laryngeal nerves, crushing, there are suggestions about crushing recurrent laryngeal nerves, and there's a variety of other different operations that have been proposed over the last sort of 30 years or so for this. In recent years, some series have suggested that a thyroarytenoid myotomy and myectomy, in other words, cutting into the muscle of the vocal fold and severing the nerve that goes to the thyroarytenoid, can be successful, and there have been some interesting long-term studies demonstrating that that may very well be successful, but clearly that's quite an ablative procedure. There's no going back from an operation where you've cut into a muscle and divided a nerve. And type 2 thyroplasty I'm going to talk about in just a moment. So going back to the injections for a moment, this is the mainstay of treatment for treating spasmodic dysphonia. We're injecting the thyroarytenoid muscle, the thyroarytenoid muscle being the one that forms the main bulk of the vocal fold, and one goes through the skin. I don't use any local anesthetic, I don't think it's necessary, so you go through the skin, avoid going into the airway, angle the needle up and laterally, so in cricothyroid membrane, angle the needle up and laterally into the thyroarytenoid muscle, and then inject. So this is me injecting a patient. You can see that the patient is wired up to an EMG machine, which just involves a couple of sticky pads on the skin. And this then tells me from the characteristic signal on the EMG machine when I'm actually in the muscle, and I can go ahead and inject. So the needle is aimed through the skin at right angles, and then having gone through the skin but avoiding going into the airway, the needle is angled up and laterally towards the thyroarytenoid muscle. When you hear that characteristic crackle on the EMG machine, you can then go ahead and inject the botulinum toxin. And that process of injecting the thyroarytenoid muscle in adductor spasmodic dysphonia, that process takes 10 seconds or so. It's really very quick if you get into the right place very rapidly. The posterior cricoarytenoid injection for abductor spasmodic dysphonia is significantly more of a fiddle under local anesthetic, and involves having to rotate the larynx. So in practical terms, I do inject local anesthetic for this because there's a bit more in the way of deep injection involved. So I inject local anesthetic into the skin, and then I will typically hold the larynx with my left hand, rotate it laterally, and then aim behind the cricoid onto the posterior face of the cricoid, feeling as I go around. And then in order to activate the muscle, in order to make the EMG machine crackle, in this scenario, you get the patient to take a deep breath in. They sniff in, and you can hear the muscle crackling. It's a lot more difficult doing a PCA injection under local anaesthetic. And in my experience, I have more patients who need that done under general anaesthetic. It's a very straightforward procedure to do under general anaesthetic, but a certain number of my patients do need a general anaesthetic to have that done. So going back to adductor spasmodic dysphonia, the Japanese have been proposing type 2 thyroplasty for a while. Type 2 thyroplasty involves an incision in the neck, dividing the thyroid cartilage in the midline, and then separating out the two halves of the thyroid cartilage to widen the space between the two vocal cords at the front, at the anterior commissure. Quite an involved operation, requires specialist bits of kit and special training. And I think the key question really is, in the long term, is this going to work? Are we going to see long-lasting results with this operation? Or, like the recurrent laryngeal nerve section and all the rest of it, is it something where the spasm is going to come back? Increasingly, it looks as if this is going to be a successful treatment, but we still need to wait, really, I think, for some longer-term results. So why do we still use botulinum toxin for spasmodic dysphonia? Well, it's got a long track record, good results. The patients tend to be satisfied. The patients are in something of a rhythm of treatment. You know, they know exactly what dose they're going to have. They know which side you're going to inject. And the clinicians, you know, from my point of view, I'm extremely comfortable doing this. I know exactly how it works at any given patient. It's a very satisfying treatment to provide. I think there's also a certain reluctance to interfere with a treatment that's working well. If it ain't broke, let's not try and fix it. And I think there's some logic in that. And patients are happy, generally speaking, with the botulinum treatment they have. And as I say, there might be a certain amount of inertia. And one could cynically argue that there are some financial considerations as well. I'm going to stop there. Thank you very much indeed for your attention. If you'd like to contact me, those are my details. I'm very happy for you to email me or contact me through Twitter if you wish. If you'd like more information on any of this or any other lectures, please do check out this book that Guri Sandhu and I have edited. I hope you've enjoyed this lecture, and I hope to see you for more in future. Thanks very much.